Good morning to all. Welcome back to Saturday Club morning meeting. And today we have a different topic. We have not talked about this topic for a long time now. So we'll be talking about a recent approach to retinal diseases. And for that, our guest speaker is Dr. Jai Prakash Purohit. He did his MS Ophthalmology from Jamnagar. He is a senior vitreoretinal surgeon in Baroda, practicing for more than 2 decades now. He is owner of Sankalp Eye Hospital and Retina Center in Baroda. He did his fellowship at Retina Foundation at Ahmedabad of very famous ophthalmologist Dr. Nagpal. He is ex-chief consultant vitreoretinal unit at Dr. Thakurbai V. Patel Eye Institute and SET ML Vaduala Eye Hospital, Vadodara, a very well-known ophthalmic institute in Vadodara for many decades. He is ex-president of Baroda Ophthalmic Society, and his areas of special interest are surgical retina, diabetic retinopathy, and retinopathy of prematurity. So, welcome Dr. Jai Purohit to Saturday Club Baroda. And you can start your talk. You have about 40-45 minutes to talk, and we'll have 10 minutes of discussion. So, over to you.
Thank you, sir. Morning, everybody. First of all, I would like to thank all of you for giving me this opportunity. We all know that medical science is continuously evolving, and when in this evolution, technology plays an important role. When this newer technology help us at various levels in management of various diseases, whether it's a diagnosis or treatment or surgical intervention, and ophthalmology is not an exception. In fact, in ophthalmology, we have seen vast development in technology. We have a lot of newer instrumentation in last 2 to 3 decades, and we are now treating various diseases which used to be untreatable few years back. So I would like to discuss these things under heading like in what we are doing recently in imaging in ophthalmology, what we are doing newer thing in medical management of various retinal disease, and various advances in surgical management. First of all, I would like to emphasize that ophthalmology is all about imaging. We use a lot of gadgets to document or image or understand the pathology by having various imaging systems. We have anterior segment imaging system where we document the cornea and lens and anterior part of the eye. We analyze the endothelium of the cornea. We measure the topography. We do use ultrasound of the eye, where it is B scan is 3D sort of 3D ultrasound. We use but especially in retina, we are mostly concerned with the imaging which is related to retina. So we use B scan ultrasound and color fundus photograph. We do infrared angiograph, OCT, and OCT angiogram. I will discuss in details for each of this. In retina, as I mentioned, these are the imaging things which we use it in our retinal OPD. Most commonly used imaging is fundus photography. For many years, this is the conventional fundus photography, which mainly evaluate the posterior pole of the retina. Here is a fundus photograph of a retina patient having a diabetic retinopathy. You can see the optic disc and various vascular structures and few other pathological changes like exudation and retinal hemorrhages. This camera used 2.5 times magnification, and the field of view usually is 30 to 50 degree of field. But with newer systems are now available where we have a field of view which is almost up to the 200 degree of the retina, and we can take the whole photograph in a single image. Like this, here you can see the retina is seen, almost entire part of the retina is visible. The image is minified, but with the optical zoom and other, you can definitely play with the image and see the magnified image of the retina. Here optic nerve is seen the same, there is a collection of exudation, you can see the almost peripheral part of the retina nicely. So this is ultra wide field fundus photography. You can compare this with standard conventional fundus camera. You can see the area of retina extensively seen in the up to the peripheral part. These are few other examples of photograph of ultra wide field color photograph. This helps us in documentation of various pathology, especially in the retinal degenerations, which are mostly in the peripheral part. And in the retinal degeneration occurs mostly in cases of myopia or high refractive error patients, where if we can document, we can visualize this, it will help us to document, and most of the time we can treat them easily. Here you can see there is a lesion which is there in the inferior part of the retina, and after documenting, we have done laser around this. This thing is very important because if we miss this subtle finding, patient can develop retinal detachment. So these are the precursors which can lead to detachment, and by having this imaging system, we can definitely pick up those lesions very easily. Though the clinical examination is not a substitute to this, most of the retinal surgeons are using indirect ophthalmoscope, and we can easily pick up these findings. But majority of the general ophthalmologists, that they are not used to, or they are not routinely doing indirect ophthalmoscopy. So for them, to document this or to pick up this lesion is very important. They can just ask a technician to take the photograph, and they can see the image, and this disease or pathology can be picked up nicely. Another investigation which we are doing routinely in our retinal OPD is fundus fluorescein angiography. Here, importance is angiography help us to understand the vascular structure of the retina, and we in this process we inject fluorescent dye in forearm. When dye reaches the retina, we take the photograph, and this is called fundus fluorescein angiography. It helps us to understand how the dye reaches to the eye. Here, if you can see, there is a pathology where there are multiple hemorrhages are there, and when we did angiography, there is a perfusion of the retina is compromised. The lower half of the retina is normal, but upper half is compromised, and there is a staining of blood vessels. There is a leakage, and this confirm it is a retinal vein occlusion, and there is a leakage at the macula, which ultimately lead to macular edema. So angiography is very important. Just by seeing the hemorrhages, you may not be aware of the vascularity, whether it is ischemic changes are there or not. This can be easily picked up with fundus and fluorescein angiography. This is again, it's a conventional camera, but when we have this wide field fundus camera, they are also now available where we do angiography, same fluorescein angiography, but here the field of view is almost 200 degree. In many retinal pathology, there are certain changes which are taking place in peripheral retina, and with conventional camera, we do miss those changes. Like this is the case of diabetic retinopathy. You are seeing there are number of leakage point. These are the new vessels which leaks in the peripheral part of the retina, and when we can document this, we definitely going to treat this, and patient will have a recovery in the vision. So ultimately, the prognosis also changes when we have this documentation and we confirm these findings with newer technology. Again, another same patient, other eye, you can see the extensive dye is leaking, and leakage of dye suggests that there are proliferative tissues, and diabetic retinopathy is all about the proliferations in the retinal vessels. So when we document this, we laser those area, and proliferation will regress, and patient will have a recovery in vision. There is another angiography not very commonly done. This is called ICG angiography. ICG is an indocyanine in angiography. It's not done routinely because it was not available. Because the cost of machine is very high, but nowadays they are also available in with this system, and you can beautifully document the lesion which are in the choroidal part. Fluorescent angiography will help us to see those pathology in retina, and ICG angiography help us to locate the disease in choroidal, which is the next layer to retina. So various choroidal pathology can be picked up very easily with this ICG angiography. Wide field angiography also important when we are looking at the central part of the retina, because the resolution of this system is so good that even you can see beautifully those central lesions as compared to conventional camera. The another system is optical coherence tomography, very popular nowadays in our retina OPD. OCT plays now very vital role in diagnosis and management of retinal disease. The beauty of this machine that in fluorescent angiography, as I said, that we do need to inject fluorescent dye, but in this it is completely non-invasive, and patient just have to sit against and there is no preparation required for this procedure. It produces the live cross-sectional image of the retina, and we can see different layers of the retina. This is like a live histological section of the retina. You can see the various layers very nicely. You can differentiate different layers. This is the inner nerve fiber layer, and here is the retinal pigment epithelial layer. This is normal anatomy of the retina. This the whole upper part is the vitreous, which is there inside the retina, and the in the outer side are the choroidal tissue. The normal, and this is completely normal retina, and you can compare them with other pathology. You can magnify the image, and beauty of this imaging system is that you can resolution is almost like 5 microns. So smaller pathology or smaller change can be easily picked up with this. Like here, clinically, this condition is called vitrofoveal traction. There is a traction which is from vitreous to the fovea, which is the central part of the retina. Clinically, it is very difficult to pick up this change on routine fundus examination, because this lesion is so small. So when we ask the patient to have this investigation, it is very easily documented this kind of changes. And this is important because most of the time patient complains us with the vision loss. They have distortion of the vision, and quality of vision is not good. Many a time they end up having some eye drops. Most of the time they act as a placebo, because this is condition where surgery is the only treatment. So OCT will change the treatment protocol, and it will guide us proper management of the disease. This is another condition where macular hole usually we can pick up on clinical examination, but OCT plays important role when we are planning surgery for such macular hole patients, because it will help us to measure the size of the hole, whether the and to assess the chronicity of the disease, which are important in prognosis of the patients after surgery. This is another condition where condition is called central serous chorioretinopathy, which is idiopathic condition. Most of the time associated with stress or type A personality are involved in this, and mostly 20 to 40 years of male are involved. Patient will present to us with sudden loss of vision. There is a patient we have a central scotoma, and good part of this, it is most of the time it is self-limiting. As I mentioned, it is related to stress. We are just reassure them, and when we confirm these findings on OCT, it completely we are 100% sure of the, because there are other change on clinical examination. It looks like macular edema, where many a time we end up using steroid eye drops or systemic steroid, which is going to worsen this situation. So this OCT will confirm this, and most of the time they have a good recovery just by observing. Age, this condition very common nowadays, which is called age, a part of the age-related macular degeneration. We have now patients who are in 17 and 80 years of their life, and age-related degeneration is a very common condition after 60 or 70 years. And this is a wet ARMD changes, where there is a collection of the blood and fluid, and there is a collection of membrane occurs from the retina, below the retina. So the collection of fluid, presence of membrane, and where the presence of membrane, presence of fluid can easily be picked up with OCT. So again, very important investigation. And when we treat this kind of disease, we don't want to have a repeated fluorescence angiography. In this case, OCT is non-invasive tool. We can do it multiple times, and prognosis or recovery of the patients and everything can be documented very nicely with this investigation. Again, presence of cystoid macular edema, most of the time post-operative patient develop such kind of disease where there is a serious collection of the fluid. Mostly they respond with topical eye drops, and post-operative patient, many a time they are very anxious when they have a good cataract surgery, and after 2 or 3 weeks they develop sudden decrease in the vision. We just confirm with this OCT, and just by some medical management they do recover well. OCT is this OCT angiography is another extension of the same OCT, where we this OCT device analyze the variation in the reflectivity and phase shift from blood vessels in the retina. So we can actually construct the microvascular flow maps, and this help us to visualize the microvascular structure of the retina and choroid without the need for intravenous injections. Intravenous injection of fluorescence. So this is a combination of fluorescence angiography and OCT, where you can actually see the vasculature of the retina, and we are not injected any dye. The OCT technology have gone through a level where we can actually see the blood flow. Though it is not a dynamic examination, we can document we can actually see the vascular pattern, whether the various structures are vascular structure are present or not. You can actually see the dropout of the capillaries. We all know diabetes is a disease of develop microvascular complications, and here you can this OCT angiography can pick up those smaller microvascular obstruction, and you can see the capillaries are occluded. This is highly magnified image of the retina, where OCT angiography has been performed, and you can see those capillary closure. This is important when we are looking at the retinopathy prognosis, because these systemic changes are irreversible, and most of the time patients end up having poor vision. So when and diabetic retinopathy many a time associated with the renal disease. So fluorescence angiography, many a times we want to avoid when patient is in that renal failure stage. So in this case, we perform this OCT angiogram, where we need not to give any dye. We just take the photograph and analyze this. OCT and vasculature can be easily seen. This is a vein occlusion patient, where if you see the upper part of the retina is normal, lower half is ischemic, and this is again OCT angiogram. We have not done any injection, and you can see the capillaries are closer, and these are ischemic changes can documented very nicely. So we have many imaging system like for color photograph, image, fluorescence angiography, ICG angiography, OCT, and we most of the time we mix up those imaging system, and we come to a conclusion or come to a diagnosis with help of this various newer systems. These are the age-related degeneration, where you can see the presence of drusen or these are the metabolic end products which are deposited on the retina, and how they are seen beautifully on this imaging system. With this newer imaging system, we have a new diagnosis or various diagnoses which we do not know before few years, and now we are treating those diseases also, because now along with this, we also have various newer treatment available for various diseases. uh, the popular mode of treatment is intravitreal injections. Intravitreal injection is not a new thing, but it is since more than 100 years. We all know that there is a blood retinal barrier which doesn't allow uh, various antibiotics and various drugs to reach. They do not allow penetrate to the level of retina. So this intravitreal mode is popular in ophthalmology in many years. Previously, it was used for various conditions like endophthalmitis, which is infection of the eye, CMV retinitis in HIV patients, various uveitis, which is inflammatory disease of the eye, proliferative retinopathy, age-related degenerations, diabetic macular edema, other macular edema related to other inflammatory disease, vein occlusions, where we use intravitreal therapy for various purposes. In intravitreal therapy, we give injection through the pars plana, which is the area 3.5 millimeter from the limbus, and 30 gauge needle is used. Each drug has there is a dosage fixed. We inject this much of usually 0.05 ml of volume is inside the vitreous cavity. The drug reaches directly on the retina, so it bypasses the whole system of body, and drug will reach directly to the area of concern, which is retina. So they give excellent result in this kind of various retinal pathology. The new thing is, which was not there before few years, is the use of intravitreal anti-VEGF. Anti-VEGF is a vascular endothelial growth factor are increase in various vascular diseases of retina, like in diabetic retinopathy of prematurity in premature babies, and various vascular disease, age-related degeneration. These molecules were not available before few years, so those diseases were very difficult to treat, because most of the time in diabetic retinopathy or other disease, we used to do laser, which is the mainstay of treatment most of the time, but laser will not improve the vision. So this kind of medication help us to improvement of the vision is there. Like in this various molecules are available nowadays. Avastin is a drug which is off-label use in ophthalmology. Mainly, drug is it's used for treatment of CA colon, but rest of the drugs are now available only for ophthalmic purpose. And these drugs are mainly anti-VEGF drug. They help us to reduce the fluid level or edema, regresses this proliferative tissues, and when edema regresses, there is definitely improvement in vision. In retinopathy prematurity, which is very common, because now we see NICU where babies are surviving almost 600, 700 grams of babies are surviving, and the ROP is present in few of those patients. And we want this baby to have a normal retina during course of their growth. But when babies are small, below 30 weeks or 32 weeks, and there is a large retinal area which is still not developed, in those cases, this intravitreal injection will reduce the VEGF inside the vitreous cavity and help retinal vasculature to grow. So we buy time to have a development of the retina, and most of the time they have an excellent result with anti-VEGF in those ROP patients. Another very common condition where we use this is the age-related macular degeneration. old age patients are there because of increasing life expectancy. Uh, uh, all all of them are highly active. Most of them are having a driving. They use mobile tablets, so they want a good visual acuity. So in age-related macular degeneration, patients have a central loss of vision, and when central loss of vision, it affects their reading, writing, or driving capability. And if we don't treat those age-related degenerative changes, it will leave scar on the macula, which will permanently give us central scotoma. When we use this drug, it will regress those membranes and help us in recovery of the vision. Unfortunate part of this injection is that it requires multiple injection, because most of them are having effect for 1 month, and disease process is many times so tough to manage, we end up giving more injections. Many a time we give monthly injection. More standard regime is to give loading dose of 3 injection, and many times we give repeated injection as and when required. There is another molecule we give is a steroid in intravitreal injection. Many times, along with this anti-VEGF, or even in inflammatory disease where there is no infection, we use injections of steroid. Commonly used steroid in ophthalmology is triamcinolone and dexamethasone. Triamcinolone we give in intravitreal dosage. Mostly they work for 1 or 2 months. Dexamethasone solution, which is available injection form, which works for 1 or 2 days only. So there is a this dexamethasone implant is available, which is called the Ozurdex, which help us to maintain the drug concentration more than 3 months. So in various diseases where steroid requirement is there, especially in uveitis patient which are associated with rheumatoid disease or various other autoimmune disease, this help us to maintain the steroid level for longer duration of period. In surgical management, we have a various, you know that phacoemulsification has changed a lot of things in ophthalmology, because when in 90s, when phaco machine was, before 90s, when machine was not there, people used to do manual incision of the surgery, and we used to take the sutures, and patient was supposed to stay in hospital for 5 years, and then recovery is usually 3 to 4 month period. But phacoemulsification has changed the scenario. Now patient is like a daycare or 1 or 2 hour job. Our cataract surgeon or phaco colleague used to say that when retinal surgeon establish a clinic, they don't require vision chart in their clinic, because their patient don't see. So why you are having a retinal vision chart in your clinic? So this was their thing from to demean us in our practice. But nowadays we have excellent various instrumentation. We have a newer vitrectomy machine. We have excellent viewing system and newer instrumentation which help us in having excellent result even in retinal disease, various disease. We newer system help us. We use smaller gauge, so there is visual. It is fast visual rehabilitation. You may not be knowing the patient has underwent surgery after 4 or 5 days of surgery. So we use 25 gauge or 27 gauge of cannulas to enter inside the eye. So we don't require to take the suture. It's most of the time self-healing. So newer technology are definitely helping us. I would like to share few of those various clinical condition where we use this. You can see the cannula size is 25 gauge. Here this surgery is for vitreous hemorrhage. Patient is diabetic. In proliferative diabetic retinopathy, their proliferative tissue bleed, and the collection of blood occurs in the vitreous cavity. We call it vitreous hemorrhage. If it remains long time, then it doesn't resolve on its own, then patient usually advise surgery. Here you can see the This is called limbus, or we enter inside the eye almost 3.5 millimeter from the limbus. Here you can see there is an implanted intraocular lens is there, and patient is diabetic. So we enter the eye through this area, which we call it pars plana. So the vitrectomy surgery is called pars plana vitrectomy. You can see that smaller gauge of 25 gauge cannula has been inserted. We insert 3 cannulas at different distance. It is like we have three uh, entry point. One is for visualization. Here you can see the light pipe is there. Another is infusion cannula, and this third one is vitrectomy cutter. So vitrectomy is not like just aspirating the fluid. In vitrectomy, it's, as the name mentioned, it's cut the tissue. So vitreous is something which cannot be aspirated. So we need to cut it and then aspirate. So here there is a port which will have a blade which will cut the vitreous, and then it will aspirate also. So you can see the vitreous hemorrhage. It is little long standing, so it is dehemoglobinized blood, and you can see the vitreous is aspirated after cutting it. When we have a system to visualize the inner side of the eye, these are the lens system, which is non-contact lens system, which allow us to see inside the eye. So you can see the vitreous hemorrhage inside the vitreous cavity. Now I am inside the vitreous cavity, and you can clearly see the blood is aspirated, or vitreous is removed gradually. Still the vitreous was in front of the retina. So now some part of retina is visible. Still the blood is so much that it's not seen clearly. But when we clear more and more vitreous, then you can see this clearing of the, and retina structure is now visible. So this is, you can see the optic nerve, various retinal vessels, and we clear this with vitrectomy. Additional procedure may require depending on the pathology, but the basic this is the vitreous removal with the vitrectomy surgery. You can see the whole of the retina is now seen nicely. Another condition, many times cataract surgery is now, as I mentioned, they give excellent results, almost we can say 100% recovery, but surgery is all about complication. We may end up having complication. Here is a case where normal lens has dislocated inside the vitreous. So this is appears like lens, but it is not. There is no lens here. So we have done vitrectomy and remove the lens from the retina. This is the lens which is inside the vitreous cavity. You can see the retina behind, and the lens is floating in front of the retina. So first thing is we need to remove the vitreous so that lens is free from surrounding vitreous. Then we use this fragmentome, which use the ultrasound power to break the lens in smaller pieces. This is called phaco-fragmentation. Procedure is called phaco-fragmentation, where lens is broken into smaller pieces, and we aspirate the whole of the lens. This normally we do it in the anterior part of the eye, but when lens is dislocated, this is how we manage it, removal of the lens. In normal phacosurgery, when this is complete removal of the lens. In normal phacosurgery, when lens is removed, there is a capsular bag where IOL is implanted. But here in this case, the whole of the lens has fallen down, so there is no support. So there is we cannot use the normal conventional lens with this, but we use different technique to place the lens. We take the sutures, Prolene 10-0, and support the lens with this suture. So this is the needle, 10-0 needles passes through this, and lens is implanted with the suture with this, and lens is now entered inside. And when this is now externally, it has been supported with sutures. So these are the how at the end of the surgery, when we close it, it's more normal. It's more like a normal phaco surgery. There is lens in place, and most of the time, patient do have a good recovery. In this case, patient has a good cataract surgery. Surgeon has implanted the lens, but unfortunately, support for the lens was not good. The intraocular lens has subluxated inside the eye. And in this also, we do it by removing the lens. We do with this is how we prepare for implantation of the another lens. We make an incision, we remove this lens, and same way which I've shown in the first surgery, we implant the lens. We remove the vitreous, which is disturbing the otherwise implantation of the lens, which doesn't allow proper centration of the lens. So here we are removing vitreous, and then at the end we have implanted the lens. Very common condition in our retina OPD is retinal disease, retinal detachment. Here you can see the retina is settled in the central part. Same we do vitrectomy, but if you carefully see this is the part which is almost normal. But there is a nasal part of the retina is detached. We remove the vitreous first. Here, if you can see the difference of retina, here this portion is detached, it is balloonous, and this portion is flat. So nasal side of retina is detached. There is a hole formation, which in this case there is a hole which lead to retinal detachment. If you see, this is the how the hole is there. Sorry. There is a hole which is there. We aspirate the fluid from the behind of the retina, and we flatten the retina, and then laser is done around the hole, and retina is now settled. We manage in various trauma cases also. In this case, there is a presence of intraocular foreign body. Uh, Foreign body has entered inside the eye. It is there. We remove the, as normally we do in all cases, we remove the vitreous first. This removal of the vitreous, and then we locate this foreign body. This is a small foreign body which is inside the vitreous. With the vitrectomy, we separate it from the surrounding tissue and make it free so that we can take it out without damaging the normal retina. Most of the time, this is metallic or magnetic. Most of the time, they are iron chip, because industry or wherever they are, mostly it is iron particle or iron piece. So here we use those intravitreal magnet and hold it with the magnet, and can remove through the sclera, and you can see this is completely removed. Then rest of the cleanup is done to prevent further damage. If there's a time, I would like to stress on one condition, which is diabetic retinopathy. We all know the burden of diabetes is very high, and it increases globally. It is also in increasing numbers in India. And another concern of in India, we have a large chunk of patients who are still undiagnosed. And when we talk about diabetes, the common condition in diabetic is diabetic retinopathy, and it is coming up as a common cause of legal blindness in age group between 20 to 70 years. we all know risk is very high when patient is insulin dependent, but it is also high, very high in non-insulin. Almost 40% patient may develop retinopathy. We know the duration risk factor for retinopathy is duration of the diabetes, poor control of diabetic retinopathy, pregnancy, hypertension, nephropathy, obesity, hyperlipidemia, smoking. There are the various risk factors. I will not go into detail, but generally it is diabetic retinopathy is proliferative and non-proliferative with or without associated macular edema. We see various findings in retinopathy diabetic fundus. We manage the retinopathy by doing laser, which is the mainstay of the treatment. When proliferative changes are there, we laser those areas. Nowadays, we have injection, as I discussed, intravitreal injections, anti-VEGFs are available, which help us to reduce the proliferative tissue as well as reduce the macular edema, which will help in improvement in the vision. Surgery is there in advanced stage of the disease. Uh, they are now routinely done, but advanced cases are usually very tough to manage. So the screening of retinopathy is very important because most of the time diabetic patients are not aware of diabetic retinopathy. They don't know, and here the role of physician comes, or any clinician who have a diabetic patient. It is very important to emphasize them about the regular screening of retina for diabetic retinopathy. Uh, since few years, we have a joint effort. We have done a lot of screening camp along with IMA and All India Ophthalmic Association, and we do at our level, but I'm sure we all are physician and we understand the importance of screening. So wherever we have a platform, I would like to make them aware about the retinopathy changes, and it needs to be done at every level, whether it is a general practitioner, physician, surgeon, whoever is there. Ask them to have any diabetic patient when it is in front of you. Ask them to have a retina checkup by any ophthalmologist. It need not to be a retinal person, because any ophthalmologist can pick up these findings. Thank you.
Thank you very much, Dr. Purohit. That was very informative talk, very detailed with a lot of graphics. So even as a non-ophthalmologist, I enjoyed the whole talk so much. So are there any questions, comments, please, from the audience?
Dr. Purohit?
Yes, sir.
This was a corona time for 2 years. So there was a micro thrombosis, and the hyperthrombosis has led to one case. I saw that there was a central retinal vein thrombosis,
yes, sir,
which had a peripheral scotoma, and
yes,
then a 36-year-old female without any, because there is no treatment, and VGSF and this thing is for some established disease, and it went away on its own. My question is, can it be prevented for a young person of 36 for future?
Sir, COVID had a different reason, but in generally without COVID also we do see such kind of thrombotic changes in young patients, especially in patients where the B12 deficiency or even homocysteine level is high. Those patients, most of them are vegetarian, and we do see those cases. And just to have a regular this supplement can prevent, but in COVID era, the pathology was, though there were many undetected COVID cases and or even established cases of COVID, as you mentioned, the hyper coagulability increases. So we don't have as such any treatment to prevent, but these are the few things we can do, supplement with certain medicine.
There is a question from Dr. Sulin Trivedi about average age of diabetics when intervention has to be done, like laser, etc.
Sir, it's not about the age of the patient, it's the age of the diabetes, the duration of the diabetes. So I would not say that though each and every patient will require treatment, But diabetic retinopathy, I would like to stress that any patient of diabetes should have a first screening within 5 years of the detection if it is in non-insulin dependent diabetes, or any insulin dependent diabetic patient should have a screening within a first year of their diagnosis. So normally when we see this kind of retinopathy, they usually develop after 5 years. So it's most of the time they don't require treatment in the early stage. Importance is to make them aware about the regular follow-up. So if you see the percentage, 5% of the patient will 5% of the diabetic patient can have some changes of retinopathy, and which can increase up to 20% of all diabetic patients have some changes of diabetic retinopathy. So out of them, almost 5 to 6% may have a disease which requires some sort of treatment. So I would not say any exact age, but screening should be start after within 5 years, and then we take a call depending. See, many patients, they maintain their blood sugar level well, and they don't have other risk factor. They have an excellent retinal condition. They don't require any treatment. But few unfortunate patients, they require, even in younger age patients, we do treat those patients for retinopathy.
Thank you. Any more questions or comments?
So screening is to be done at the time of diagnosis and subsequently every 5 years, if there is nothing wrong.
Yes, at the time, if patient is insulin dependent, suppose a young patient in 10 or 20 years of age, if they found to be having insulin dependent, then better to have a first screening. And then depending on the clinical condition, we do advise yearly checkup, or if but after 5 years, I will say that once in a year is mostly advisable to at least one retinal checkup.
So in type 1 diabetes, no, it has to be done at what age we start and how frequently we do that in children.
So, as I mentioned, first screening at the diagnosis time, and then depending on the condition, we if disease is there is no retinopathy, normally we advise yearly checkup. But if they found to have some changes, then we reduce the duration 6 months or even 3 months, depending on the progression of the disease.
So it's on case to case basis, you decide the frequency of monitoring.
Yes, yes.
So
in your practice, Satish bhai, in your practice, Dr. Purohit, which are the drugs like artificial reproductive systems which are going on nowadays? You know, the hormone therapies and things like that. There have been increase in retinal damage due to the treatment or the drugs. Which are the drugs we should be careful by, which can damage retina?
I'm not sure any drug for this. You mean IVF treatment?
No, which are the drugs in practice in medicine which can have a probably side effect as retinal damage or vascular damage?
Sir, there are conditions like rheumatoid arthritis, where these people, rheumatologists or physicians, give HCQs. They develop retinal changes over a period of time. So it is important that we screen those patients at least once in a year, because when we detect those changes in early, and damage is usually reversible. So pick up those things. So HCQ is one drug. Then there are various antipsychotic drugs, though they mention in this, but not. I have not seen many drugs which lead to retinal damage. Very commonly seen damage because of ethambutol. We see many patients of tuberculosis because ethambutol is what I understood. It's a drug most of the physician love to give, because of, I don't know, but they most of the time it is at the first regime is always include ethambutol, and ethambutol has idiosyncratic changes. It develops optic neuritis, and most of the time it is irreversible. So along with the ethambutol, mostly they give B6 as a supplement, but we do see those cases of optic neuritis with ethambutol.
Ethambutol is very much part of any primary, line
Yes,
of
sir.
antituberculous therapy, and we give this vitamin B pyridoxine for peripheral neuropathy, and doesn't prevent
Optic neuritis. Yes, sir. Yes, sir.
Anyway, Dr. Sulin has one more question regarding pediatric diabetic data. I mean, probably what he wants to know is that how often you come across retinopathy in adolescents who are insulin dependent.
Not because probably the awareness of the disease is more, which I see in pediatric or insulin dependent patients, because they are feed with a lot of things, so they have a regular screening. So I don't see many, but when we see retinopathy, usually they are very bad retinopathy. We have most of the time proliferative disease, and it goes hand on hand with nephropathy also. So when the kidney is compromised, most of the time retina is also in bed phase. So I have not seen many retinopathy patient in especially pediatric age, but when they grow or when the duration of the diabetes increases, suppose the diagnosis occur at the age of 5 or 10 years, when they reach their 30s or 40s, there is a duration is almost like 30 years of duration, which is another very high risk factor. So we don't see in that pediatric age, but most of the time when they reach at adult stage, the duration is so that they have a very advanced stage of the disease.
I think the question, next sub-segment of the question was regarding HbA1c level. So obviously, I think retinopathy is related to the control of diabetes. Poorly controlled diabetics have more chance of
so the
retinopathy.
two major factor is, one is duration of diabetes and second is control of diabetes. So any uncontrolled diabetic patient will going to develop retinopathy.
Right. So here we end the discussion, and thank you very much, Dr. Jaiprakash Purohit, once again for being with us. We do expect you in future for some more advances, and as you said, diabetic retinopathy, I think, requires more attention. So someday we'll have a talk on that also.
Sure.
So thank you very much. Thank you all. We end the meeting here. We meet again.